We're your dedicated guides, taking the most important and often complicated source material, extracting those critical nuggets of knowledge, and giving you the shortcut to being truly well-informed. Today, we are undertaking a massive deep dive into respiratory pharmacology. We're looking at the science, the mechanisms, and the molecules behind treating two of the most universal but fundamentally different respiratory issues. A simple, bothersome cough and chronic, life-altering bronchial asthma.
It's a fascinating comparison. It really is, because the treatment strategies range from the purely symptomatic, which often includes centuries-old folk remedies, all the way to cutting-edge, targeted anti-inflammatory monoclonal antibodies. Our source material gives us this brilliant, comprehensive overview, and our mission today is to understand not just which drugs are used, but why. Why is the clinical rationale behind them so vastly different?
Exactly. Our target is to move past that superficial, what drug does what, and answer the deeper questions. Why is suppressing one cough helpful, but suppressing another actively harmful? And how did we fundamentally shift our approach to asthma care from just, opening a tight airway to managing this underlying chronic state of cellular inflammation?
And to do that, we need to start at the absolute beginning, with the most fundamental protective reflex we possess, the cough.
Okay, let's unpack this. Because for most of us, a cough is just an inconvenience. It's loud, it's disruptive, maybe it keeps you up all night. But fundamentally, it's a crucial defensive mechanism.
That's absolutely correct. The cough is a highly specialized, fast, and protective reflex. Its sole design purpose is the rapid expulsion of respiratory secretions.
And any foreign particles.
Any foreign particles that have found their way into the air passages. It's triggered by the stimulation of, either mechanoreceptors sensing physical irritation or chemoreceptors, which sense chemical irritation.
And those are in the throat and the airways.
In the throat and respiratory passages, or sometimes by stretch receptors deep in the lungs themselves.
So when we feel that tickle or that irritation, that's the signal telling the central nervous system, warning, foreign material detected, initiate expulsion protocol.
Precisely. And this understanding leads directly to the core clinical decision point in cough management.
The first fork in the road.
The first big one. We have to distinguish between a useful cough and a useless one. This is the first critical distinction we need to flag for you.
Okay, so let's define that. A useful cough is?
A useful cough is what clinicians call productive. It's serving its evolutionary purpose. It is effectively draining the airway, clearing debris, phlegm, mucus.
It's getting the job done.
It's getting the job done. And if the patient is effectively moving that material up and out, suppressing this type of cough is often undesirable. You want to let the body finish its clearance job.
So you hear that wet, rattling cough, you often need to resist the immediate urge to suppress it. Maybe help it along, but not stop it.
Exactly. Conversely, the useless cough, the non-productive, dry, hacking, irritating kind, that's the one that causes strain, exhaustion, potential damage, but provides zero clearance benefit.
That's the cough that should be suppressed.
That's the one. And this is symptomatic treatment, which is non-specific. Of course, the specific treatment would be, say, an antibiotic for a bacterial infection, but most coughs we treat are symptomatic.
And this sets the stage perfectly for our first set of symptomatic remedies, the non-antitussive drugs.
Right. These fall into three categories that attempt to manage the mucus or the throat irritation rather than suppressing the brain's cough signal itself.
Let's start with the simplest, oldest approach, pharyngeal demulcents.
Demulcents are really straightforward. Their mechanism is mechanical. They are sticky, sugary, or viscous compounds that just coat and soothe the irritated pharyngeal mucosa, the lining of your throat.
So the lozenges, the thick syrups, the glycerin, or the licorice, they're essentially just tricking the nerve endings in the throat to stop sending that primary irritation signal up to the brain.
That's a perfect way to put it. They physically reduce the afferent impulses, those incoming signals, that trigger that initial irritating cough reflex.
So it's purely symptomatic relief.
Purely.
Yeah.
For a dry, scratchy cough that's coming from upper throat irritation. They don't touch the lungs, but they silence the tickle.
Okay, next we move into a category that is widely known, widely marketed, but comes with a huge asterisk: expectorants or mucokinetics.
This is where we need to introduce the skeptic's view immediately. The definition of an expectorant is a drug believed to increase bronchial secretion or reduce its viscosity.
Believed to. I like that phrasing.
Yes, believed to facilitate its removal by coughing. And while they are a huge market segment, objective evidence of their efficacy is, frankly, non-conclusive.
What are the main methods these compounds use to try and achieve that goal?
Well, there are three classic approaches detailed in the source material. First, there's the salt action. Compounds like sodium and potassium citrate are used, which are thought to increase bronchial secretion volume by irritating the gastric mucosa and reflexly stimulating the respiratory tract.
And what about potassium iodide? I see that mentioned.
Potassium iodide also falls under that salt action as it's secreted by the bronchial glands, theoretically thinning the mucus. However, it's very rarely used now.
Why is that?
Because prolonged use can seriously affect thyroid function and lead to a condition called iodism.
That sounds like a heavy price to pay for a minor cough.
It is. The second approach is the reflex action of nauseating drugs, like ammonium salts. The nauseating action reflexly increases respiratory secretions. It's an indirect and, frankly, unpleasant way to try and achieve clearance.
And the third?
Finally, we have the ubiquitous plant products, guaifenesin, Vasaka, Tolu balsam, all traditionally supposed to enhance secretion and mucociliary function.
Guaifenesin, of course, is the one that has survived the regulatory cull.
Indeed. And this is a point we really need to put a spotlight on for you. Because the evidence base is so weak, the U.S. FDA has stopped marketing nearly all expectorants except for guaifenesin.
Wow.
And many of the marketed expectorant formulations are sold in fixed-dose combinations, FDCs, with other drugs, despite all this clinical skepticism.
So if the objective evidence is so shaky, what's the best advice for actually clearing thick airway mucus?
The clinical takeaway is often surprisingly simple. Adequate systemic hydration, just drinking enough water and steam inhalation, may be significantly more effective and safer than relying on many of these marketed expectorant preparations.
That's a powerful conclusion about an entire category of drugs.
Now let's move to the mucolytics. These are chemically more sophisticated because they actually attack the structure of the mucus itself.
Mucolytics are fundamentally different. They're only indicated when the patient has truly thick, tenacious, often immovable sputum or mucus plugs. We see this in specific diseases like chronic asthmatic bronchitis, cystic fibrosis, or intubated patients.
Let's start with bromhexine. What's its chemical trick? Bromhexine is a derivative of the alkaloid vasicine, and it acts as both a mucolytic and a mucokinetic. Its mechanism is twofold. First, it directly depolymerizes the mucopolysaccharides that form the structural backbone of the mucus.
It breaks the glue.
It breaks the glue. And second, it liberates lysosomal enzymes, which break up the complex fiber network in the sputum.
So it's really cutting the internal structure holding that thick sputum together.
Precisely. It thins the sputum very effectively. Its metabolite, ambroxol, has similar actions and is used in the same context.
Next on the list is acetylcysteine. This one is often used in a hospital setting and has a very potent chemical mechanism.
Acetylcysteine is highly potent because it directly liquefies sputum by opening the actual disulfide bonds in the mucoproteins.
Okay, what are disulfide bonds?
They're critical for the viscosity of the mucus. They're like these chemical crosslinks. Breaking them turns that thick, sticky gel into a manageable liquid.
And it's used in several ways, orally, by inhalation, or even directly instilled.
It is very versatile. It can be administered by nebulized inhalation as a 10 to 20% solution, or directly instilled into the respiratory tract. However, you flagged a crucial caution earlier regarding the oral route.
Right. So a drug designed to help the lungs can actually compromise the stomach lining. How serious a risk is that if it's taken orally?
It's a genuine concern. Oral administration of acetylcysteine may breach the gastric mucus barrier, and that naturally leads us to carbocysteine, which is another orally administered liquefier of viscid sputum.
And carbocysteine carries an even stricter warning about the stomach.
It does, because it also works by breaking that crucial gastric mucus barrier. Carbocysteine is absolutely contraindicated in patients known to have peptic ulcers.
So this is a vital reminder.
Yeah.
Even seemingly straightforward symptomatic treatments can have deep pharmacological consequences, often impacting systems far removed from the lungs.
That's a powerful transition because now we are leaving the airway itself and moving to the brain. We're discussing antitussives, shutting down the cough center entirely. And this is where the conversation turns to careful use, addiction risk, and, well, ethics.
Right. This third category of cough management really requires the most careful clinical judgment. We only use antitussives for a dry, non-productive cough, or, critically, when the cough itself is dangerous.
Or debilitating.
What are some examples of when the cough itself poses a threat?
Well, if the cough is unduly tiring and it's disturbing sleep over prolonged periods, that's one indicator. More seriously, if the patient has a hazardous underlying condition,
Such as?
such as a hernia, severe hemorrhoids, severe cardiac disease, or has recently undergone delicate ocular or abdominal surgery. In these cases, the physical strain of the cough carries more risk than the benefit of any minor airway clearance.
So we are talking about drugs that act centrally in the
Mm,
CNS to raise the threshold of the cough center, essentially making the brain require a stronger signal to trigger the expulsion reflex.
yes. And the gold standard for effectiveness, historically, are the opioid antitussives.
Morphine being the most effective, but entirely unsuitable.
Exactly. We steer clear of morphine due to its powerful addicting properties and its potent ability to depress respiratory function across the board. The standard we compare everything else against is codeine.
Codeine is an opium alkaloid that is less potent, but much more selective for depressing the cough center than morphine is.
It's the benchmark. It typically suppresses a cough for about 6 hours. We know it works via opioid receptors because its action is readily blocked by the opioid antagonist naloxone. But even codeine has significant drawbacks.
Constipation being the primary most common complaint.
That's the chief issue. But the more serious risk, particularly if doses are escalated or used with other sedatives, is respiratory depression and profound drowsiness, especially in children. It is strictly contraindicated in asthmatics and anyone with diminished respiratory reserve.
The sources also mention its close relatives. Ethylmorphine, believed to be less constipating, and fulcadine. Fulcadine sounds like it offers a major advantage.
Fulcadine is fascinating. It provides similar antitussive efficacy to codeine, but has a longer duration of action up to 12 hours and, critically, virtually no analgesic or addicting properties.
So it's safer from a dependency perspective?
Much safer. It's metabolized slowly, making it a better option from that perspective, though it still has its own set of side effects.
Now let's talk about the effort to get the benefit of cough suppression without that risk of opioid dependency. The non-opioid antitussives.
The first one we encounter is noscapine, or narcotine. Although it's an opium alkaloid, it belongs to a different chemical series. This is key because it depresses the cough without the narcotic, analgesic, or dependence-inducing effects of the morphine derivatives. It's particularly useful for spasmodic coughs.
But it comes with that allergy-related warning for asthmatics.
Yes. Noscapine has the capacity to release histamine. For a patient with already hyperreactive airways, this histamine release poses a genuine risk of producing bronchoconstriction, potentially triggering an asthma attack.
And the most famous non-opioid globally is dextromethorphan, or DM.
DM is a synthetic central NMDA receptor antagonist. And what's truly clever about its synthesis is that the D-isomer provides the pure antitussive action, while the isomer is the one with analgesic properties.
So they isolated the part that stops the cough.
They isolated the D-isomer, so they achieved central cough suppression without affecting pain perception or causing typical opioid side effects like constipation or depressing mucociliary function.
Even though it's clinically considered non-addicting, we still hear about its abuse potential.
That's the complex reality. While it won't cause classical physical dependency like codeine, drug abusers do indulge because at high doses, DM acts as a hallucinogen.
What does that look like?
It causes symptoms like confusion, hallucinations, and ataxia. This is why its use requires significant caution and is often restricted in young children.
And rounding out the central suppressants, we have clofidionol.
Clofidionol is a bit of a pharmacological cocktail. It has central antitussive action, combined with weak antisemintic, anticholinergic, and local anesthetic properties. Its onset is slow, but it offers a longer duration of action.
Before we leave cough treatment, we have to tackle the topic of adjuvant drug classes and irrational combinations, the FDCs. This is a crucial section because it moves from pure pharmacology to clinical skepticism.
It is. This is a major area of concern in pharmacy today. Many H1 antihistamines drugs like chlorpheniramine, diphenhydramine, and promethazine are routinely added to cough formulations.
Why are they added? Is it for a true antihistamine effect?
Not primarily, no. They are added because of their side effects, their prominent sedative action, and their anticholinergic properties.
Okay, so what do those properties do?
Well, they can dry up secretions and cause drowsiness, which reduces the patient's perception of the cough and helps them sleep.
But they lack selectivity for the cough center itself.
Exactly. And their anticholinergic action may actually thicken secretions, making them harder to clear. Critically, second-generation antihistamines like loratadine, which are non-sedating, are completely ineffective as cough remedies. If you're not sedating the patient, you're not helping the cough.
Then we see bronchodilators like salbutamol added to cough syrups.
And this is only rational if there is an element of underlying bronchoconstriction aggravating the cough, like in chronic smokers or patients with known hyperreactivity. Using them routinely in fixed-dose combinations is problematic.
Okay, let's stop here and really zero in on this FDC issue. This is the ultimate irrational critique from the sources. Why are these combinations so flawed in their fundamental design?
The problem is twofold. First, they often combine opposing goals. You'll have an expectorant, which tries to thin mucus and encourage a productive cough,
Right.
combined with an antitussive, which tries to suppress the cough center entirely.
So you're sending contradictory signals.
You are literally telling the body to expel the mucus while simultaneously telling the brain not to bother initiating the expulsion reflex. It is pharmacologically nonsensical.
That makes perfect sense. They clinically cancel each other out.
And secondly, combining a central antitussive with a high anticholinergic antihistamine adds a layer of risk and sedation that is often unnecessary for a simple cold. While some of these FDCs have been banned in certain regions, the reality is that many are still marketed and heavily advertised.
So the point we really need to emphasize for you is that the majority of these fixed-dose combination cough formulations are not only irrational, but, as the source material states, they often have nothing more than a placebo effect. It's an industry built on this hope of simultaneous relief that simply doesn't materialize.
And that contrast between the irrational mixtures in the cough aisle and the strictly rational, calculated combination therapy necessary for asthma is the perfect segue into our next topic.
Yes, let's make that crucial shift to bronchial asthma. We have to start by acknowledging that our foundational understanding of asthma has matured dramatically.
It really has. It's no longer simply viewed as a muscle that suddenly spasms shut.
Right.
Asthma is recognized primarily as a chronic inflammatory condition. That inflammation is what underlies the bronchial hyperreactivity, that exaggerated response to stimuli.
And it's that hyperreactivity coupled with the ongoing mucosal edema and viscid secretions that results in the reversible airway obstruction that produces the classic symptoms.
Dyspnoea, wheezing, and yes, cough.
The sources outline two principal varieties, extrinsic and intrinsic asthma. How do they differ in clinical presentation?
Well, extrinsic asthma, which we often see in younger patients, is mostly episodic and has a clear allergic basis, often shown by positive skin tests. These patients are generally less prone to status asthmaticus.
Which is that severe, life-threatening attack.
Exactly. Intrinsic asthma, conversely, tends to be perennial. It's year-round, and status asthmaticus is unfortunately more common.
The triggers are extensive infection, irritants, pollution, physical exertion, cold air. But the why of it all is the inflammatory cascade.
The inflammatory cascade is everything. If we understand the cells and the mediators, we understand modern treatment. The infiltrate in asthma is dominated by specific cells: mast cells, eosinophils, and T helper 2 lymphocytes.
And when a trigger arrives, these cells kick off a rapid, escalating sequence of mediator release.
They do. Can I walk you through the timeline of that release?
Please.
It happens in phases. First, you have the immediate release within seconds. Mediators that are already pre-stored in the mast cell granules flood the area histamine, various protease enzymes, TNF-alpha. This is the immediate explosive reaction.
Okay.
Second, the intermediate phase occurring within minutes. This involves the rapid synthesis of mediators from membrane phospholipids, primarily prostaglandins, leukotrienes, and platelet activating factor. The leukotrienes in particular are powerful, long-lasting bronchoconstrictors.
And finally, the long game. The hours-long activation.
Yes, the late phase, which occurs over several hours. This involves the activation of genes within the inflammatory cells, leading to the synthesis of brand new proteins like interleukins and more TNF-alpha. These late mediators are responsible for recruiting even more inflammatory cells to the site, which just perpetuates the cycle.
And if this cycle goes unchecked for months or years, the physical structure of the lung actually changes.
That is the tragedy of airway modeling. The chronic inflammation causes structural changes. The bronchial smooth muscle hypertrophies, the number of mucus-secreting cells increases, and there is damage to the bronchial epithelium itself. These changes make the disease progressively worse.
We absolutely have to pause here and discuss the distinction between asthma and COPD, chronic obstructive pulmonary disease. This contrast really defines the entire treatment philosophy for both.
The distinction is vital. While both are chronic inflammatory diseases of the airways, the cellular cast of characters is different. In asthma, we see mast cells and eosinophils, a specific type of white blood cell dominating the scene. In COPD, the inflammation is dominated by neutrophils and macrophages, along with cytotoxic lymphocytes.
So why does the cell type fundamentally change the treatment strategy?
Because the nature of the damage is different. Eosinophil-driven inflammation in asthma leads to smooth muscle constriction and is highly reversible. Neutrophil-driven inflammation in COPD leads to progressive tissue damage, characterized by emphysema and bronchiolar fibrosis. This damage is mostly irreversible.
So COPD starts later, is highly associated with smoking, and the obstruction is largely permanent. Bronchodilators help, but you rarely see huge improvements in lung function tests.
Exactly. Asthma is inflammation-driven constriction. COPD is destruction-driven obstruction. This fundamental difference means anti-inflammatory agents targeted at eosinophilic pathways might work wonders in asthma but do nothing for COPD and vice versa.
The sources set out 8 pillars of asthma treatment, which really encapsulate everything we're about to discuss.
They lay out the comprehensive strategy, from antigen avoidance and patient education through the complex pharmacologic pillars: suppressing inflammation with corticosteroids, preventing mast cell degranulation, blocking leukotriene action, neutralizing IgE, and then the 3 main bronchodilator classes.
Let's begin with the workhorse of acute asthma relief, the simplified mimetics, specifically the beta-2 agonists.
These are the rescue inhalers, the cornerstone of managing acute reversible obstruction. They work by stimulating beta-2 receptors on bronchial muscle cells, which activates an enzyme, increases cyclic AMP, and causes muscle relaxation. They are the fastest and most effective way to reverse bronchospasm.
And we need to clearly separate the short-acting beta-2 agonists, or SABAs, from the long-acting LABs.
Right. SABAs like salbutamol or albuterol and terbutaline are highly selective for the beta-2 receptor. They have a rapid onset, typically within 5 minutes, but their duration is short, 2 to 4 hours. The clinical role is strictly to abort and terminate acute attacks.
And this leads to a critical flag for you as the listener: the misuse of rescue inhalers.
This is a major public health point. SABAs should not be used on a regular schedule. If a patient is relying on their SABA daily, their asthma is fundamentally uncontrolled and they need prophylactic therapy.
Because regular use can actually make things worse.
It can. Regular chronic SABA use does not reduce hyperreactivity and, alarmingly, may worsen it by causing a downregulation of the beta-2 respiratory receptors. This leads to diminished effectiveness when they need the rescue the most.
Then we have the LABAs, such as salmeterol and formoterol, designed for round-the-clock maintenance.
Salmeterol has a slower onset but is highly lipophilic, meaning it dissolves in fats, allowing it to remain bound to the receptor site for longer, giving it a 12-hour duration. Formoterol also lasts 12 hours but has a fast onset, like salbutamol. They're used for maintenance therapy, preventing nocturnal asthma, and improving baseline lung function.
But the use of LABAs alone is now associated with a truly terrifying safety concern.
This is the critical caveat that changed asthma treatment guidelines globally. Epidemiological studies show that the regular use of LABAs as monotherapy used alone was associated with an increased risk of life-threatening asthma exacerbations and even fatalities.
Do we know why?
The mechanism isn't fully clear, but it's possibly related to masking the underlying inflammation while only treating the muscle spasm. It gives a false sense of security.
So the resulting clinical mandate is absolute.
LABAs must only be used in combination with an inhaled corticosteroid, an ICS. The steroid treats the underlying inflammation, while the LABA provides sustained bronchodilation. These fixed-dose combination inhalers are the standard of care for moderate and severe persistent asthma.
Moving to the historical foundation of asthma treatment, methylxanthines, represented primarily by theophylline. This drug has a fascinating history, but a notorious present due to its toxicity.
Yes. Theophylline is restricted today primarily because of its narrow margin of safety. It's now reserved for COPD and as an adjuvant in selected cases of refractory asthma. It's part of a family of naturally occurring alkaloids alongside caffeine and theobromine. Theophylline is recognized as a more potent bronchodilator than caffeine.
Let's detail its wide-ranging pharmacological actions. It doesn't just act on the lungs.
No, it's a systemic stimulant. It causes generalized CNS stimulation, though not as potently as caffeine. It's a cardiac stimulant, increasing heart rate and force of contraction.
Which can lead to arrhythmias.
Exactly. At high doses, it is a general, smooth muscle relaxant, with the bronchial relaxation being the most therapeutically relevant effect, and it acts as a diuretic, increasing urine output.
We need to dive deep into its mechanisms as our sources detail 3 ways it works, including one that's relatively new.
Okay, the 3 mechanisms are complex. First, the historically cited one, release of calcium from the sarcoplasmic reticulum. However, this only happens at concentrations far exceeding the therapeutic range, so it's likely not the main action.
The second, and most famous, is phosphodiesterase, or PDE inhibition.
Right. PDE is the enzyme that breaks down KMP, the messenger that relaxes bronchial muscles. By inhibiting PDE, theophylline prevents KMP from being degraded, thereby increasing KMP levels and causing sustained bronchodilation.
And the major problem here is that theophylline is a weak and highly non-selective PDE inhibitor.
Precisely. It inhibits multiple PDE isoenzymes throughout the body, which contributes to its wide array of side effects: the cardiac stimulation, the CNS effects, the GI upset. This non-selectivity is why science sought out selective inhibitors, like roflumilast, a PDE4 inhibitor approved only for COPD.
The third mechanism involves adenosine receptor antagonism.
Adenosine is an endogenous signaling molecule that typically causes bronchoconstriction. Methylxanthines act as competitive antagonists at these adenosine receptors, producing the desired opposite effects. This antagonism is believed to be responsible for the serious arrhythmias and seizures seen during toxicity.
Now for the new insight, its anti-inflammatory potential at very low doses.
This is a promising avenue. Even at plasma concentrations below the bronchodilator range, the therapeutic window is 5 to 20 micrograms per mil. Theophylline appears to enhance histone decetylation in airway inflammatory cells.
What does that mean in simple terms?
It's an epigenetic modification that suppresses pro-inflammatory gene transcription. It lends it a genuine, though weak, anti-inflammatory role, separate from its ability to open the airways.
But despite that potential, the narrow margin of safety dictates its restricted use. This is the learner's warning we have to emphasize.
It is perilously narrow. Dose-dependent toxicity often starts near 20 micrograms per mil. Early symptoms are the mild ones: headache, nervousness, nausea. But because there is high variability in how people metabolize the drug, the progression to severe toxicity can be rapid.
Can you detail the progression into the danger zone?
As plasma concentrations approach 25 micrograms per mil, you start seeing profound agitation, cardiac extrasystoles, restlessness. Above that, the risk is severe: delirium, and at the highest concentrations, life-threatening events like convulsions, severe cardiac arrhythmias, circulatory shock, and potential death. The danger is very real.
Our final category of bronchodilators is the anticholinergics, which work by blocking the nervous system's constrictor signals.
Drugs like ipratropium bromide and tiotropium bromide cause bronchodilation by blocking 3-MON3/3 muscarinic receptors. This reverses the persistent cholinergic constrictor tone that runs through the vagal nerve.
We noted earlier that their primary site of action is different from the beta-2 agonists.
Yes. They act predominantly in the larger central airways, which are richly supplied by the vagal nerve. Beta-2 agonists, by contrast, mostly relax the smooth muscle cells in the smaller bronchioles.
And this makes them the superior choice in COPD.
Absolutely. Because reflex cholinergic tone is the major reversible component of airway obstruction in COPD, anticholinergics are the bronchodilators of choice. The long-acting tiotropium bromide, which provides 24 hours of action, is highly effective for maintenance therapy in COPD patients.
In asthma, they're less effective than beta-2 agonists, but they still play a crucial synergistic role in emergencies.
They do. The combined use of ipratropium with ASABA is strictly additive and provides better bronchodilation than either drug alone. This combination is leveraged heavily, often via nebulization, for terminating severe exacerbations of both asthma and COPD.
We've established that modern asthma care is driven by anti-inflammation, not just bronchodilation. Let's now look at the prophylactic treatments that fundamentally change the long-term prognosis.
And the absolute undisputed king of this approach is the corticosteroid. We cannot stress enough that these are anti-inflammatory drugs, not bronchodilators.
This is the foundation.
It is. Glucocorticoids are revolutionary in asthma because they are the most complete and sustained form of symptomatic relief. They work by inhibiting the production of inflammatory cytokines, suppressing the infiltration of those problematic eosinophils into the lungs, and ultimately reducing bronchial hyperreactivity.
The advent of inhaled corticosteroids, ICS, truly changed the game.
It allowed us to deliver potent anti-inflammatory action directly to the airway while minimizing systemic side effects. Drugs like beclomethasone, butzenide, and fluticasone are designed to have high topical activity but poor systemic absorption.
Can we talk about the clever mechanism of the newer ICS, cyclosinide?
Cyclosinide is a fantastic example of pharmacological ingenuity. It's administered as an inactive prodrug. It only gets activated by enzymes after it's deposited in the bronchial epithelium.
So what's the benefit of that?
It means that what is absorbed into the systemic circulation is largely the inactive parent compound. This drastically minimizes the exposure of the active drug to the rest of the body, providing better safety margins.
When is ICS use indicated?
They are indicated for all cases of persistent asthma, even the mildest chronic forms. They are strictly for prophylaxis, preventing future attacks by controlling the underlying disease. They are ineffective if used during an acute attack because their efficacy takes 4 to 7 days to fully manifest.
And what about the practical side effects that people might encounter?
The side effects are primarily local: hoarseness, a sore throat, and oropharyngeal candidiasis, commonly known as thrush.
A fungal infection.
Yes. The good news is these can be dramatically reduced by simple techniques: using a spacer device and instructing the patient to gargle thoroughly and spit out the water immediately after every use.
So if ICS are the workhorse, systemic steroids are the nuclear option, reserved only for the most difficult cases.
Precisely. Oral steroids like prednisolone or IV hydrocortisone are the last resort. They're used for severe chronic asthma that remains uncontrolled despite maximum ICS and LABA therapy, or for treating status asthmaticus.
And the risks associated with long-term oral use are why they are avoided at all costs.
The risks are profound and systemic. Long-term use necessitates keeping the dose at an absolute minimum due to concerns like osteoporosis, adrenal suppression, growth retardation in children, and early cataract formation. The strategy is always to try to wean the patient off.
Shifting away from steroids, let's look at the agents that target those specific inflammatory mediators we identified, the leukotriene antagonists.
These target the cysteinyl leukotrienes, which are those powerful, long-lasting bronchoconstrictors. Drugs like montelukast and zafirlukast competitively block the CySL-T receptor.
What makes them useful in the clinical setting?
They are excellent prophylactic options for mild to moderate asthma, particularly in children where a daily pill might be preferred over an inhaler. They are also uniquely effective in 2 specific types of asthma: aspirin-induced asthma and exercise-induced asthma.
Suggesting leukotrienes play a major role in those specific triggers.
Exactly. But their limitations are clear. They have no role in terminating an acute attack, and they show no established value in COPD, reinforcing that cellular distinction we made earlier.
Let's briefly touch on mast cell stabilizers, like sodium cromoglicate. They prevent the release of those immediate mediators.
Sodium cromoglicate inhibits mast cell degranulation. It stabilizes the cell membrane so that when the allergen hits, the pre-stored mediators aren't released. It's used for prophylaxis, primarily for extrinsic and exercise-induced asthma.
But the clinical utility is limited by its timing requirement.
Yes, it is not a bronchodilator and is entirely ineffective if given during an asthmatic attack. Its benefit, if achieved, develops slowly over several weeks. It has largely been superseded by ICS.
Finally, let's discuss the highest cost, highest complexity solution, the anti-IgE antibody, omalizumab.
Omalizumab is a high-tech solution, a humanized monoclonal antibody. Its mechanism is very specific. It binds to and neutralizes the free IgE circulating in the blood.
And IgE is the key antibody for allergic reactions.
It is. It's what binds to the mast cell surface and triggers the whole cascade. Neutralizing it preemptively disarms that allergic response.
Given its cost, who is it reserved for?
It is reserved only for patients with severe extrinsic or allergic asthma who require frequent hospitalization and have measurable high IgE levels. It offers zero benefit in non-allergic asthma.
We've covered the entire pharmacological arsenal. Now we need to discuss how these powerful drugs are delivered, and then, most critically, the strategic guidelines that dictate when and how they are used.
Delivery is paramount in respiratory medicine. The goal of inhalation delivery is to minimize the total dose and systemic side effects by targeting the drug directly to the airways.
And the physics of particle size determines success.
Exactly. We aim for particles between 1 and 5 micrometers in diameter. That's the sweet spot for deep deposition in the bronchioles. Particles larger than that primarily deposit in the oropharynx and are swallowed.
Let's discuss the 3 primary delivery systems, starting with the ubiquitous metered-dose inhaler, the MDI.
The MDI is a pressurized handheld canister. Its major drawback is the need for excellent patient technique. They have to coordinate the device actuation with a slow, deep inspiration.
And if they don't?
If they don't, most of the drug just hits the back of the throat.
Which is why the spacer device is so vital.
Spacers are chambers that attach to the MDI. They dramatically improve drug delivery by eliminating the need for precise hand-breath coordination. They hold the aerosolized drug long enough for the patient to inhale it slowly, and crucially, they slow the velocity of large particles, reducing their deposition in the throat.
Which minimizes those local steroid side effects.
Exactly.
Next, the dry powder inhaler, or DPI.
DPIs require the patient to inhale the powder with a high-velocity, deep inspiratory force to successfully aerosolize the drug dose. This is a significant limitation for young children, the elderly, or patients in acute distress who can't generate that necessary force.
And finally, the nebulizer.
Nebulizers create a continuous fine mist of drug solution. They're preferred for severe acute episodes, for children and for the elderly, because they require minimal effort and can deliver high doses of synergistic combinations like salbutamol and ipratropium simultaneously.
Now we synthesize everything into the strategic framework, the stepped approach to treatment. This ensures you understand the clinical roadmap for chronic asthma management.
The stepped approach is mandated by major guidelines and is built on the premise that treatment intensity must be tailored to the severity of the patient's condition. The ultimate goal is 0 symptoms and 0 exacerbations.
Step 1, the mildest scenario. What does this look like clinically, and what is the treatment?
Step 1 is for patients with mild, infrequent episodic symptoms. The treatment is the absolute minimum. Inhaled SABA, like salbutamol, used as needed. No continuous prophylactic therapy is necessary.
Step 2, when the asthma becomes persistent or chronic.
This is a major change in strategy. Step 2 is for mild persistent asthma. This requires the initiation of regular prophylactic therapy. The undisputed standard here is regular low-dose inhaled corticosteroid. The alternative is montelukast, but relief may be less complete.
Step 3, where we introduce that mandatory combination. What warrants this escalation?
Step 3 is for moderate asthma. Here, we add an inhaled, long-acting beta-2 agonist, a LABO, to the ICS. The ICS is now used at a low or medium dose. This combination is highly effective.
But the LABO is not necessarily a forever drug.
That is a crucial nuance. Due to the safety concerns, if control is maintained for several months, an attempt should be made to step down the therapy, ideally discontinuing the LABO and reverting to ICS monotherapy.
Step 4, for severe asthma that still isn't controlled.
Step 4 is a further dose increase. The treatment involves regular high-dose ICS, ideally with a large volume spacer combined with the LABA. If control remains elusive, you can introduce add-ons like a leukotriene antagonist or cautiously oral theophylline.
Step 5, the last resort for refractory cases.
Step 5 is for the most challenging patients. This is where we introduce oral steroid therapy prednisolone while continuing the high-dose ICS and LABA. The clinical priority is to keep that oral steroid dose absolutely minimal.
Finally, the critical emergency, status asthmaticus.
This is a life-threatening exacerbation not responding to initial bronchodilators. Immediate management involves high-flow humidified oxygen, followed by massive doses of intravenous glucocorticoids, usually hydrocortisone.
And we utilize that drug synergy here.
Absolutely. The bronchodilator strategy is high-dose nebulized salbutamol combined with ipratropium bromide, often driven by oxygen, to maximize the additive effect. Intravenous aminophylline is now severely restricted, reserved only for resistant cases, because it rarely offers additional benefit but significantly raises the risk of life-threatening toxicity.
What an incredible journey. From understanding the subtle differences between a useful cough and a useless cough, all the way to a 5-step, highly calculated strategic approach to managing a chronic inflammatory disease.
We've seen that in cough management, skepticism is key. We must be wary of irrational fixed-dose combinations that combine opposing pharmacological goals. In contrast, in asthma, the most effective modern therapy is defined by a necessary, calculated combination.
The inhaled steroid paired with the long-acting bronchodilator.
For long-term safety and efficacy.
We've highlighted the dangers of foundational drugs like theophylline, with its narrow therapeutic index, and the risks associated with chronic elbow A use when not paired with an anti-inflammatory agent.
And this sets up the ultimate challenge for future respiratory medicine. The goal is clear. We must move completely away from the need for high-dose systemic steroids, which carry such devastating side effect profiles. The solution lies in finding highly selective molecules. We know roflumilast targets PDE4 and COPD, showing the potential for targeted anti-inflammatory action.
So knowing how highly specific our current generation of drugs has become, and seeing the complexity of the inflammatory cascade, especially those mediators released in the hours-long late phase, the question we leave you with is this. What novel inflammatory mediator that is currently beyond our reach will be the next successful target that finally eliminates the need for high-dose oral steroids in refractory asthma once and for all?
That research could save countless lives.
Thank you for joining us for the deep dives. We hope you feel thoroughly informed and ready to navigate the complex world of respiratory pharmacology.